Good afternoon, everyone. This is Andy Reese with Department on Disability Services. Um, First up, I will share our current data. So, uh, are people seeing my notes or are you just seeing the slide?
We are seeing your notes, Dr. Reese. The notes.
For some reason. Okay, I'm going to switch this to sharing a different screen. The benefit of so many screens. Now we're good, right?
Yes.
I just need to be cautious because there are times that I may have identifying information in a note, and I certainly would want to share that in a presentation with folks. So, in the month of December, September, unfortunately, we have now had 10 new COVID infections, bringing our total to 444 people supported by DDS who have been diagnosed with COVID. Um, of those 10 this month, 6 of them were vaccinated, 4 had not been vaccinated, and all 4 of those were people who were in their natural homes. So by placement type, we have had 9 people in host homes, 114 people in intermediate care facilities, 1 in a mental health facility, 61 in natural homes, 2 in a nursing home, 4 in out-of-state placements, 41 in residential habilitation placements, and 212 in supported living. So within ICS, those 114 people with COVID reflect about 38% of people in ICFs who have contracted COVID. Of those, we've had 13 confirmed COVID deaths, which is about 11.4%. And there have been 28 people who have been diagnosed with COVID and have gone on to die, reflecting about 24 to 25%. In natural homes, the 61 people are about almost 7% of the people in natural homes who have contracted COVID. Of those, there have been 5 who have died, and all 5 have been confirmed as COVID deaths, which is about 8% of people in natural homes who contracted COVID and then died from COVID. In residential habilitation, the 41 people represent about 38% of people in residential habilitation who have contracted COVID. Of those, 3 have died, 2 were confirmed as COVID deaths, which reflects about 5% of people in residential habilitation who contracted COVID and then have a confirmed COVID death. 212 people in supported living have contracted COVID, which reflects about 22% of people in supported living. Of those, we've had 22 of them have gone on to die, but only 15 are confirmed COVID deaths. So that represents about 7% in supported living who contracted COVID and had a confirmed COVID death. Overall, 444 people represent about 18% of people supported by DDS who have contracted COVID. There have been 37 confirmed COVID deaths among them, reflecting about 8%. A total of 61 deaths, but many of those have been confirmed as not COVID related. So in the month of September, the 10 people who contracted COVID, 5 were in natural homes, 3 in supported living, and 2 in residential habilitation. As we look at those, fortunately, none of them have required inpatient treatment for COVID. We've not had a person who's required inpatient treatment since April of this year. And people who have had COVID who have died, there have been 61. Of those 61, 16 have been confirmed as not COVID related, and we are still awaiting the cause of death for 8 of those people. And so therefore of confirmed COVID deaths, we've not had a person die from COVID, from a confirmed COVID, since March of this year. Provider staff, there were 2 more provider staff that tested positive, bringing the total 727. 52 of these have been reported by more than one provider as contracting COVID, and we have had 10 staff who have died from COVID. Vaccination rates ticked up just a little bit. People supported by DDA, it's still at 78%. Within host homes, it's at 83%. Within ICFs, at 98%. In natural homes, is at 62%. Residential habilitation is at 96%, and supported living is at 86%. Among our provider staff, the most recent report we have is at 73%. And among DDS staff, our most recent report from just a few days ago is at 88%. Just as a reminder to people, if you want to ask a question, please scroll down to where it says everyone. I want to make one announcement and then introduce, we have some guests with us today from Station MD who will be doing a presentation. I do see someone saying that they're on the attendees list. So I assume, Kirk, that everyone who we hope is presenting is available. But just to let people know, we did receive word this morning that our Appendix K has been approved. Our most recent amendment, which would be number 6, has been approved. And that's the one that will allow for retainer payments retroactive to January 1, 2021. It's the same as the prior year's retainer payments, and an additional supplemental payment for DSPs that will be the same as the payment that is being made by DHCF right now. So, Kirk, if you could introduce our folks from Station MD.
Andy, I'm going to turn it over to Donald Clark to do a brief introduction.
Hey, good afternoon, everyone. Donald Clark from DDS. As promised from last week's Provider and Community Forum, we are joined today by Station D telemedicine services, urgent care telemedicine services. This is a very big initiative for DDS as far as rollout for FY22, where our goal is to really provide this extra layer of support to people we provide services to in rehab, ICF, host home, and supported living settings. So without further ado, I'd like to throw this over to Dr. Trivedi to give our overview of Station MD, discuss what the user experience looks like for any of the people we support to access this service. And sorry if you were at the Provider Coalition meeting yesterday. This is the same presentation. However, we think this is very important that we cast the wide net as far as sharing this information and making sure providers in the community are aware of this project that's coming forth in FY22. Thank you.
Great. Hi, Donald. Can you hear me okay?
Yes, we can hear you.
Thank you. I'm going to try to share here. Can you see that all right?
Yes, I can.
Okay, great. First and foremost, again, I want to apologize to everyone who's going to hear my annoying voice again, but we just think it's important that the word gets out about what we are doing here at Station MD, and I want to thank again DDS for giving us the opportunity. I'm going to go ahead and jump right into it, but please, if you have questions, add them to the chat, or I'm happy to answer them at the end of the presentation. Again, really, this is the gist of what our goal is at Station MD, is to really help achieve superior care for vulnerable individuals. That is the individuals with intellectual and developmental disabilities. That is all we serve. We deliver that care using telehealth and telemedicine. DDS has been wonderful to work with and has funded this service for individuals, and we're in the process of working out some of the details on how that will be rolled out. The purpose of this session is just to give you an idea of what we do, what services we are going to be providing, and how we are going to really help elevate the care for individuals. A little bit of background about our organization, founded by emergency medicine physicians. I myself am an ER doctor. I've been practicing for many years, and really this was born out of our own experience in the ER, thinking that there's a better way to treat individuals. We are currently providing this service to over 30,000 individuals in 12 states, and have been doing this for about 7 years or so now. We're just members of some of these organizations, which you may be familiar with. We consider ourselves advocates, and we are always looking to really advance the medical field for these individuals that we are serving. And these are just some partners that we have. You know, the thrust of a lot of our work in the beginning was to really help reduce ER utilization. Individuals with IDD tend to use the ER more frequently than other groups for a variety of reasons, which this slide kind of speaks to, whether they're comorbidities such as pulmonary or GI or behavioral. They use the ER. And when they go to the ER, they tend to get hospitalized more frequently. The causes of this frequent ER use, as I mentioned, is they do have comorbidities that make them more susceptible and to having to go there. Simple issues such as fever or rash or complicated medical concerns become more of an issue when an individual has comorbidities. There is just a lack of access otherwise. Sometimes that is the only place an individual can go. Even if the individual has a primary care physician, that physician may not have the resources we have to visualize them, or they may not be available. So oftentimes the urgent care ER is the de facto course of action. And then again, there are regulatory requirements. If an individual falls, or you may have certain protocols where the individual needs to be seen by a physician for an evaluation. The goal of Station MD is really, how can we assess an individual in a non-disruptive, stable environment and keep them at home whenever possible? Just some background, which most of you are probably familiar with, is how the ER can be a frightening experience for most people. We've just spoke about COVID, and that is still real. So if we can keep an individual out of the emergency department, you're also keeping that individual safe, but also the DSP or whoever family member is going with them. It is frightening. It's for someone who has sensory issues. It takes weeks to stabilize sometimes, and it's very disruptive. And I always mention that, you know, sometimes in my career, I've seen individuals come simply for a med refill, and it's really not the place to get the care that they deserve. And this slide just speaks to that. It's really suboptimal care. It's unspecialized care. One thing I forgot to mention is that all of our physicians at Station MD, aside from being board certified physicians and licensed obviously in DC, are also specially trained. They go through a specialized curriculum to understand the needs of this population. So that is critical in caring for this population that we serve. A lot of times, unfortunately, doctors don't really understand both the clinical and non-clinical needs. The other aspect, of course, I mentioned is exposure, and then all of this also adds up to excessive costs. This is just a slide to speak about COVID. We just saw previously, some of the cases that you had mentioned. Fortunately, we're on a downswing, but having an intellectual disability was deemed the strongest independent risk factor for presenting with COVID and dying from COVID. And this was a study that was published in the New England Journal of Medicine. So challenges for provider organizations, those tasked with caring for individuals. Of course, I mentioned the regulatory issues, but staffing is a real issue. Shortages of staffing, turnover, overtime pay. So we help support those individuals that are supporting the people that we're caring for. So we provide a resource. One thing I always want to emphasize is that we are not an extra burden to the individuals. We are there as a support staff, 24 hours a day, 7 days a week. If you need a physician to speak to clarify anything, answer a question, we are there. And so we really help support the staff that's caring for individuals. And this is just some of the other issues that I mentioned with the staff that they're dealing with. So just to speak real briefly about telehealth and telemedicine. As you're probably aware, it is something that has been widely adopted in a viable means of delivering healthcare. We argue that having telehealth for individuals with IDD is even greater value because they have these issues of transportation, or they can't get to a specialized doctor, or they rely on someone else to take them. So I do think it is going to be the standard of care. We just like to think that for this population, you really need a specialized telemedicine. The benefits, again, we can be anywhere as long as there's a cell signal or Wi-Fi signal. It decreases costs, and it really allows for a safety net, allows for individuals to live independent, productive lives. On the left are the problems. As I mentioned, lack of access. There are no geographic impediments to what we do. The suboptimal care, all of our doctors, as I mentioned, have the specialized training. We do have access to medical records. We have our own EHR and database. We're available 24 hours a day, 7 days a week, and everything we do, we document immediately. We also want to emphasize we're not there to replace the primary care physicians. We're there to augment and handle any urgent medical issue. But if it's a med refill, a clarification, any incident that you may need to be addressed, we can handle that. We've also developed guidelines. We have physician training. We do quality reviews. We have an educational series that we've developed for our physicians, but also for the provider agencies that we work with. Our platform is actually a HIPAA compliant Zoom. So, if you can get on Skype or Zoom or FaceTime, you can use our solution. That being said, we have 24/7 support. We have training videos. We do weekly virtual training for staff. And then we also employ navigators. And these are individuals that help walk you through the steps, just in case, you have trouble with your microphone or can't get the video to work. And they are on every virtual consultation that we do. And this is just a screenshot of our platform, which is really accessible to anyone that you would give access to, which shows who was called, when they called, what was the diagnosis. All the physician notes are kept there, and you can also run records off of that. And this is just a little bit more about that data, what some of the analysis you can do off of it. And this is a screenshot of the educational lectures that we've developed. We have about 20 or 30 of these, which are common issues that we see in our practice. These are all evidence-based best practices created by our chief medical officer, and these are available as part of our solution that DDS is going to be providing. Lastly, I'll give you a quick example of a process, and then I will stop talking, hopefully answer any questions you may have. And this is a case that I've discussed before of a 24-year-old with cerebral palsy and asthma, developed a cough and a fever. That's the change in condition. So that change in condition is what prompts the provider or DSP or whatever process we end up, the nurse activating Station MD. It's a toll-free number. We've had the individual preloaded in our system, and then we do our assessment. In this specific case, telemedicine consultations initiated. We have a high-def camera. We have a Bluetooth stethoscope. And I would do my assessment. From the individual's end and the DSP's end, it's just really one button that they would press to access, and the consultation begins usually within minutes. And in this case, the thought was of there was an asthma exacerbation with a respiratory infection, we can e-prescribe meds. They're delivered or they're picked up. This is not a once and done thing. I called back in an hour. The SAT's improved. Everything is documented in the electronic health record, and the PCP is notified. This whole process maybe took half an hour or so, and a trip to the ER was avoided. It's more than a substitute. I believe it's superior care. In my experience as an emergency medicine physician, you probably would have taken hours to get there. You may have waited for hours to be seen by a physician, blood work, and possibly been admitted to the hospital. We also arrange for follow-up. We can, like I mentioned, we notify the primary care physician, but we have a nurse that we employ that can call back the next day and reassess the individual and see how they're doing. Not all cases need to be that emergent. We do med refills, questions, constipation, behavior changes, anything you may need some medical advice on. And lastly, these are just the outcomes. About 90% of the time, we keep the individuals in place, meaning we don't need to send them out. And these are just some of the calls. The blue are the ones that we keep in place. The gray are the ones we send out. And I do want to also let everyone know that if we send someone out, we will call the ER in advance or urgent care or wherever they're going and let them know. It helps oftentimes expedite the care that they're receiving and avoid some unnecessary tests they may be receiving. I think that's it. I can happily put my information in the chat box, and let me just stop sharing there for a second and see if there's any questions.
Yes, there's one question coming in. It reads, do people with IDD have to be pre-registered for the service?
So I will defer to DDS about, but I don't know, Kirk, if you wanted to add anything to that, or?
No, so pretty much we are rolling this out through all of our residential settings in different phases. But the intention here is that folks in phase one for ICFs and residential habilitation will be enrolled in this service as part of their general Medicaid services offer. So there's no pre-registration needed.
Correct.
Yeah, and just to clarify, we'll be getting an eligibility file from, or have gotten one from DDS, and that's uploaded into our system. So we'll have the information readily available when people do make the call to us.
I'm going to put in my email in the chat box. So if you have other questions, I guess I wanted to emphasize again that DDS has been really progressive in taking this step to provide this service. The goal is to roll this out to as many individuals as possible. And we want to serve as a resource to you. So my mantra is, if you're not sure when to call us, please call us. If you have questions, the only reason you wouldn't is if it's a life-threatening or limb-threatening issue where you would normally call 911. But we are working out the exact process so that every agency knows that this service is available. So thank you.
I see another question coming. I probably could have answered the first one I read, but I'll read the question and answer this one. The question says, will you provide equipment or resources needed? Because I heard the use of the Bluetooth stethoscope. Yes, that is part of our rollout. DDS not only has considered covering the cost of the monthly fee for people to access Station MD, but also for the equipment that needs to go along with it. That is part of our rollout to deploy equipment to those sites. I'll also take this time to also add that to serve as a FYI to providers that look for a email to come about the next steps. That's very important that you look out for that and you're responsive, because that is going to make the process of transitioning to the service way more seamless. And of course, based on that previous question, also helps with the process of deploying equipment to those sites.
Thanks, Tom.
Yeah, and just to clarify that, so once that first email blast goes out, then you'll be getting emails from Station MD, and we will send you the number, the people that we have at each address that are enrolled in the service, which is pretty much going to be everyone at that particular address. But just so there's no confusion, And then once we are ready to deliver the equipment, we'll be setting up a schedule. The equipment deployment process is very easy. It takes about 10 or 15 minutes per home. We kind of come in and out and get, keep out of everybody's way. But we will definitely be giving you a heads up when that equipment will be coming and an estimated time on that day that it will be coming as well. And we'll give you, certainly ample time so that when it will arrive.
Thanks. I see there's one question real quick about, do you employ physicians on a full-time basis, and is this their only employment? Some of our physicians do this full-time. That's their only that's the only thing they do. Some of them do this and work in other emergency departments. But I want to emphasize that all of our physicians, when they work at Station MD, this is all they're doing. They're on like a shift. Some other telemedicine, they may be at dinner or they may be out, and that's not how we operate. They're at a secure location, and this is their primary responsibility for whatever shift time is. And again, we operated almost like a virtual ER. So I hope that answers the question.
There's also a question about whether the PowerPoint can be shared.
Oh, yes. I did send it to Kirk, has it. I'm happy to share it with anyone else. But he has a copy, and yeah, happy to share it. Sure.
Yeah, and
Do
also
we
a pre-recorded version of the PowerPoint will actually be in some of the materials that Donald will be sending out in his email blast. You'll be getting a link to a bunch of different materials. So we'll be in there as well.
And we typically post the PowerPoint from our forum on our website. So if that's okay, we would convert it to a PDF and post it on our website along with our data.
Great.
I see there's a question, but it's not about Station MD. So before I get to that, are there any other questions regarding Station MD? Okay, well, I really want to thank you for coming today so that you could provide this overview for people. We're really excited about seeing this launch. And, I know that it's been an issue for years here in the district, the issue of the high rate of emergency inpatient hospitalizations and emergency room utilization. And so we're hoping that this will address those concerns. So we really look forward to this moving forward. Thanks for coming today.
Thank you. My pleasure. Have a great weekend.
So at the end of last week's call, Nelson Vanucci reiterated the DC Health guidance that a person supported by DDA who is vaccinated but exposed to COVID-19 must remain quarantined for 14 days. It says even if they test negative. As I wrote in my blog this week, this is Carol Grigsby, that is at odds with community integration for people with disabilities who may have just returned to jobs or other community responsibilities. It could easily put people's employment at risk, particularly if they do not have an adequate leave balance, but also affects others who are going into the community after a long COVID-imposed isolation. I'd like to hear from both DC Health and DDS about what's being done to update a policy that, while possibly sensible before widespread vaccination, is now merely punitive. And I know Nelson and Daryl are both here.
Thank you, Director Reese. As I stated last week, this guidance is based on the currently posted quarantine guidance, and I can put a link in the chat. And I also want to clarify that it is not all person supported. It's based on the setting and where they live. So, for example, someone in a host home would follow community guidance and not this guidance. So what this says is healthcare facility and congregate settings, staff, residents, and patients, including correctional detentional facilities, homeless shelters, intermediate care facilities, community residence facilities, and supported living, must adhere to 14 days of quarantine. And so this is the guidance I believe that is being referred to, and this is what I talked about last week. We appreciate and validate and hear what you're saying. And what I can tell you is that there are discussions about this guidance and the questions that are being posed. And I will also state, as I had before, that the decision to keep a guidance or to change a guidance is based not only upon CDC recommendations, but also about community, the spread in the community and data to show potentially breakthrough infections in those that are fully vaccinated and other epidemiological considerations. And so it's not something that we change lightly. And so we are having continued discussions. And that's all I can really say about that at this time.
And in terms of it being directed to DDS, the health guidance is, DC Health does coordinate with us. We provide input to them, but at the end of the day, the recommendations regarding health guidance are certainly within the purview of DC Health. From Daniel Darby, I'm highly concerned seeing that 73% of provider staff are vaccinated. Knowing that we are a week away from not having these staff, this is concerning. I wonder about quality of care given the number of staff that will be lost. This, coupled with the nationwide DSP shortage, provides great concern. We've submitted many suggestions to DDS and DOH that have gone unanswered to date. Can DDS comment on the potential disaster that's looming? First of all, just to clarify, 73% is staff who are fully vaccinated. So my hope would be that, and by September 30th, staff have to have gotten their first shot if they're getting the 2-shot combination. So that actual number could be a little bit higher. I don't know what suggestions you're referring to. So if you could type those in, I'd be interested to see them. There is a mandate for the vaccination. So I don't know the suggestions that may have come in because I am not aware of them. I am aware of the written questions that were here, and DC Health responded to them. We sent them out to providers, but we should also just post them on our website along with the other things from our forum so that people can see the written responses from DC Health from questions that were written in on September 10th. Why is supported living, which may be a person living alone, covered by a congregate settings policy? And I don't know if that's something you can respond to here, Nelson, or just take that away as a comment, because I do think understanding the whole range of circumstances for people in supported living is essential when considering recommendations for all people in supported living. Did you want to provide any response or just take that comment back as DC Health continues to consider the guidance that they provide?
It's duly noted. Thank you.
Concerning residential placement on the vacancy list, okay, so there are a number of questions here about residential vacancies. What's the referral process for residential placement? Is there a limit on the number of referrals to a provider on an annual basis? I think that, as a provider with a human care agreement approved for 4 years, excellent PCR since inception and without a single referral to residential placement, what needs to be addressed by the provider to progress to the next steps in this process, notwithstanding the new development protocol? our vacancies closed for underperforming agencies so that they can open vacancies for well-performing agencies. And perhaps Winslow could respond to this. I mean, the first thing that jumps to mind for me is we have a lot of current vacancies. And I believe that when new providers come to us, one of the things that we talk to them about is the reality that we do have a number of providers and a number of current vacancies, and we're going to look first at those vacancies. So starting as a residential provider can be quite challenging for that reason, but perhaps you could address this more specifically, Winslow.
No, well, it's a question that I get calls on a lot. The first thing I would say is that in this great country of ours, if I wanted to start selling hamburgers, I could. And when I go to get loans, they'll give them to me. I'll start my business and I could start selling hamburgers. But if I don't do the front end research to realize that there's a Burger King, a Wendy's, a McDonald's, and there are only certain number of people who actually eat ground beef fried, if I haven't done that front end research, I won't say I can't be upset when my hamburgers don't sell. So what I see is a lot of people who get in this business, they hire consultants who are either former employees of DDS, people who are familiar with how the system works, and somehow believe that there's this magical cadre of people with disabilities needing support. There are 2,400 people that we support. And within that number, many of them live at home. So if you don't do the math on the front end and then you get a human care agreement letter, very clearly a letter that states you're eligible for a human care agreement. That's like me being eligible to drive a car, but never actually getting a driver's license, or getting a driver's license and not having the car. Do I get to drive? I got a license. That doesn't mean you can play the game of driving a car if you don't have a car. So long and short of it is, a lot of people come into the business wanting to be providers because they either work for providers, they've heard of successes of current providers, and then expect that there's this magic number of people. Now, that's one point. The second point is, if we have what are called vacancies, and I'm going to be very clear, a vacancy is not you going out and renting a building and you have a letter saying you could be a human care provider and you have an empty bedroom that you're paying for. That's not a vacancy. A vacancy is an approved location that we currently have put people in, and then someone moved out, unfortunately died, or what have you. That's a vacancy. You don't have a vacancy unless you've actually had a person in that unit. So long and short of it is, I really wish people would hear this message. If you want to sell hamburgers, learn how many people are selling hamburgers, learn how many people are buying hamburgers before you go and spend money to sell hamburgers. There's not that many people needing residential vacancies. Residential placement first. Second, there are a number of empty locations we pay for. And thirdly, and most importantly, people gravitate to Wendy's, McDonald's, and Burger King over Winslow's hamburgers because they have heard, know about, and have proven that they can sell hamburgers. So I'm sorry that if I've been long-winded with this issue. I've been dealing with this for years, where people seem upset that they can't get a referral. It's not that you can't get a referral, it's that you don't have a human care agreement. So if I've got empty locations that I'm paying for, we have a responsibility to the citizens of DC to be responsible. If we're spending money for empty locations, why would we go and spend money to create another location? So,
thank you.
sorry.
And I'm not sure who I'm punting to for the next question. I just know I'm punting. So the appropriate person could identify that themselves. As MCIS is set to update next Friday, October 1st, what date time frame has been identified for providers receiving training on new updates and requirements? We want to ensure that all necessary information to have a seamless transition through the changes has occurred.
Hi, good afternoon. I will take this one, Director Reese. So we sent out an email yesterday at 5 p.m. It should have went to all providers in our network. The training dates have been identified as Tuesday, September 28th, Wednesday, September 29th, and Thursday, September 30th from 11 a.m. to 12 p.m. I will put that in the chat, but again, this email went out to all providers at 5 p.m. yesterday, Thursday. Thank you.
Can DDS at least address the issue of community integration that I posed in my comment? I'm sorry, but what you're doing is challenging DC health guidance. And so, no, I can't really. I mean, what I can say is that we work with DC health on these, and, you know, we provide input about these concerns. You know, and I know that it's an issue that we've provided from the beginning, sort of a lot of education around what supported living looks like, because those are not DC health licensed placements, so that they could understand. And as either Daryl or Nelson said, in making these recommendations, they're looking at the current data about community spread, about the folks there. And so, you know, as it relates to what DC health guidance is, that ultimately at the end of the day is DC health guidance. Oh, it has been mentioned in these forums each week. The same issue remains. What is the status in securing some responsiveness on TME that's trained medication employees applications and processing? It is continuing as an issue, and it's causing further scarcity in the ability to provide for providers to lend support. And Winslow, I know you've followed up on this some. I don't know if there is any update.
So, well, we referred this to DC Health. They have responsibility and regulatory authority over licensure and certifications. They're aware of this concern. I have not received any new information. All I was told was that they added locations where people could test, that the test as was recommended. I did share that, you know, there was a concern that the test should be online, where people could access it easily. And I know that they have a vendor. I believe there were some concerns with that vendor, and those concerns have been noted, but I can't really speak for Dr. Lewis and her team at DC Health. And I don't know if any of them are on the call, but we have at DDS shared that concern a couple of times recently, and we have no new information. So, no, I understand about getting them approved. As I've shared with you personally, Ian, in meetings and directly, they have one person that's approving all nurses, LPNs, I believe, one person, and you shared her name with me, and I knew her from when I was on the board, but there's only one person processing all applications. So, you know, that you're mentioning this, I'll reach out to her, but I can't speak for their processes and how they operate. But I will again reach back out to them.
So from another provider, I agree, Danielle, our organization is struggling to hire nursing and DSP staff prior to the September 30th mandate. and know that our organization is not alone, as we have received calls from other provider agencies asking for help. We want to ensure proper coverage and provide quality services, and would love to hear successes in recruitment and retention, as several staff will likely be losing their jobs due to the mandate. So if people do have that to share, that would be very helpful. Some of the unanswered questions revolve around notice that an exemption request has been made. Who gets the response? Can the employer be looped in? We've recommended an integrated system that offers a receipt that is provided at least to the submitter. I'm pretty certain that when you submit something to that portal, that it does acknowledge having received it. I would also say, if you have an employee who is seeking a waiver and you hire that employee, they should be getting you should know that they have documentation for the waiver, so they give it to you. That's kind of separate from the individual giving their information to DC Health. So keep in mind, we have two different things going on here. One is, especially for licensed professionals, it's very clear. If you want to maintain your license in the District of Columbia, you're going to need to, at the very least, begin that vaccination process before the end of this month. And before you go to renew, you're going to have documentation in the system that you are fully vaccinated. And all of us can see whether licensed professionals are at that point or not. Unlicensed, it is a bit harder because DC Health generally is not tracking them, but is not tracking them as, as people who provide this service. But what the regulation requires is that for unlicensed persons, they must have if they are not getting vaccinated, they must have a waiver that's approved by DC Health. And the written response to that question and the verbal response last week from DC Health was that as long as a waiver request has been submitted by the 30th, it's considered a request. As a provider, the qualifications for DSPs have been amended to include that they must be vaccinated against coronavirus. So we have our provider certification review process, and the folks who do that meet every week. They review any updates to requirements for the provider and then add those new requirements, including this vaccine mandate, to their provider certification reviews that are done. So you should know as a provider that when your next PCR comes up, you need to be able to provide documentation that a person has been vaccinated or has a waiver. And it is true that you're going to need to, an approved waiver is going to be one that's been approved by the Department of Health, but you do need to make sure for yourself, if the person isn't vaccinated, have you seen some documentation of a waiver? And as I said, my understanding from people was that when they submit that there is an acknowledgement, we have received this. And so, you could ask your staff to print that out and give it to you. I don't know if there's anyone from DC Health that has more practical information about their portal, but I think in that regard, people are overthinking this. You're hiring people, they need to be vaccinated or have a waiver. Go through that process because you as a provider are also making those decisions. If there is the possibility that you will approve a number of waivers that DC Health doesn't approve, and that I think could get complicated. But for right now, ensuring that you have at least, facially, like that you're meeting what the regulation requires. And expecting an integrated system, I don't think is reasonable because it would mean sharing health information of the individual with someone else. And as all of you know, people work for a variety of different employers. So, yeah, it's an individual mandate. And so the system is set up for individuals to submit their information. There were also questions submitted. We urge DC Health to develop a format for the exemption submission. Will a doctor's note need to be on letterhead or will a script suffice? What kind of a doctor will be considered? What level of detail will need to be included about the underlying medical issues? And how will such a request not simply be approved by DC Health, since DC Health will have no ability to refute what is written? On the religious exemption, what level of detail about the practicing habits of staff will DC be examining? What kind of supporting documentation will be required? How will sincerely held beliefs be evaluated? We would like some direction on these in writing as well. I'll communicate that to DC Health. I will also say I know that the deadline for the district government is the earliest deadline. And so they are just now seeing the variety of exemption requests that people have submitted and beginning to get an idea about how to answer some of those questions, quite frankly. And as I said, providers are employers in their own right and have that requirement in their own right. And so, I think that, for example, we have one provider that had a mandate since last December and managed to evaluate all of these requests on their own. There's the information. Kirk has posted the information regarding the case management training in the chat box for people that want to review it. Thank you for adding some of the suggestions. I know that some suggestions are out of DDS's control. However, as the oversight agency, it is important that DDS understand the predicament that providers are in and advocate to help avoid the looming crisis. I know providers feel like we're out on an island without a life raft. And so there's a comment here from Holistic. We were told that DC Health is the only party that can approve an exemption, and that is true. That what the new regulation says is for staff who request an exemption, it has to be approved by the director of DC Health. So that, for providers who have had a vaccine mandate that includes those same exemptions for a number of months, those staff would still be required to submit whatever they had submitted previously to DC Health for approval. And keep in mind that every exemption is only approved on an annual basis, so that it would have to be resubmitted each year. If a provider has the documents to request a waiver, how do we know what is acceptable to DC Health, and how do we know that it has even been submitted? For the second question, what I would say, what I have said, and I believe, although like I say, I don't think there's anyone from DC Health responsible for the portal, but I thought their representation last week is that when you submit your information, and I expect at least some of your staff have already done this, that you get some acknowledgement from DC Health that it has been received. And so that would be how you would know that it had been submitted. And then the challenge is going to be that the staff would have to provide you with the response when they received it. And I would, this is just speculation, and speculation is probably dangerous. Yeah, I mean, I think I'm not even going to go there. I think the challenge is that, well, what we have as a written response from DC Health at this time is from the time that a waiver request was submitted, the person can keep working until you hear that it's not been approved. We haven't yet heard, and I don't know that DC Health can know, because they don't know how many of these they're going to receive, how long it will take to give an answer. However, for your staff who submit them, if you at least have evidence from them that was received, you know, it seems that you're in good stead there. Additionally, some licenses do not expire until 2022. How do we know if the person has an exemption that has been denied if they have not applied for a renewal? Well, their license would still be good until 2022. And, you know, this is, like I said, I think that we'll have a better idea about the time frame for considering and ruling on the waiver requests as this thing completely rolls out, because we don't know how many requests they will be receiving. And once the system is up and running and we know how long it takes generally, then you can start raising questions about how come everyone else has given me their acceptance of their waiver request and I've seen nothing from you. Unfortunately, though, like I said, I don't see that there's a way to link the individual to the agency they work for in that system, or at least that is not something that DC Health has included in the system. And because it's health information, I think there's some significant challenges. Why is there no weekly testing requirement for DC healthcare professionals seeking or granted a waiver? But there is a testing requirement for DC government employees. So the district government is an employer, and all of our providers are employers. And in the regulation, it allows for one, it allows that providers can have any increased requirements they wish, including a testing requirement. The district government has a testing requirement, but you know that, and the district government, I will say it's both stricter and more lenient. The district government allows currently for weekly testing for people who are opposed to the vaccine currently. So let's say we have an existing person who submitted a waiver. DCHF, for some reason, I've lost the interpreter on my screen. Just making people aware of that. I can see you in a little box up at the top, but Kirk, somehow the person who's on center stage has switched. Just if we could make sure for folks who rely.
Yeah, sure, Lisa, can you give me back host right, please? Host rights, thank you.
And regarding the TME issue, I'm going to reach out to Dr. Lewis again today. I was on a call with her earlier.
Winslow, sorry. As long as we don't have an interpreter, I prefer that we not.
Oh,
There we go. And I'm just noticing it's already 1:05, so let me just see if I can quickly get in some of these others. So let's say we have an existing person who submitted a waiver. DC Health has 2 months to make a determination. I'm not sure that that's true. I don't know that there is a requirement regarding how long DC Health has to make the determination. If 15 days in, they get their exemption declined and they don't inform us of this and they are still working, what is our liability? I would suggest that you speak with your own attorney about that. I mean, I'm not going to give people legal advice. Maybe if I wasn't a lawyer, it wouldn't be as bad. But I would suggest you speak with your own counsel about that, because I do know what my answer would be. The acknowledgement for submission does not indicate a name. I'm not clear on if it is the status for confirmation of submission for an exemption. We'll have to see if someone from DC Health familiar with the portal will be available next week, since there are so many questions about how that works. Now, if you could answer your TME question. Sorry, Winslow.
yeah, I just, what I was saying is that I just reached back out to Dr. Lewis and I'm going to call her again on this issue. And because of the questions centered around the exemptions, I also will raise those with her as well and see if she can have someone available who can speak directly to these questions by next week.
And I'll just, since we are over, next week is after the deadline, which is true. Ideally, however, your staff are presenting to you evidence that they've gotten their first vaccine. The reality is, I would expect the percentage of people who have a sincerely held religious belief or a medical reason for not getting the vaccine is going to be a significantly small percentage of your staff. And so what we really need to be focused on in this last week is getting people their first shot so that we don't have any of these gaps. So another rather fast hour went by. Sorry that we can't respond more fully to people's questions. I hope everyone has a good week, and I hope that, lots of folks who are still outstanding get their vaccination. The numbers seem to be turning around in DC a little bit, and I hope they continue in that direction. Have a good weekend, everyone.